This is an ortho-K case where the patient is getting cylindrical post-wear refraction, whereas the initial refraction was mostly spherical. And if we look at the topos, you can see that it's coming from the astigmatism right here, and right here it's a little bit irregular, and I think that's what's causing the monocular diplopia that your patient's got. I've seen a few cases like this, and there's good news and bad news. Bad news is sometimes I have not been able to get rid of this. The good news is if this case is for myopia control, it will still work well. I do have patients who have exactly this small bow tie appearance, which causes a little bit of doubling, and I have the patient wear spectacles during the day as needed, and we're still able to maintain good control of myopia progression. I don't know if that's the goal specifically in this case, but regardless, we do want to at least try to get as good vision as possible uncorrected. So I'm going to bring up the most recent lens for the right eye, and what I would recommend with this case is to reduce the optic zone and introduce a little asphericity. So what we want to do is get more uniformity right at the center of the patient's visual axis. Right now I have the most recent design. It's in free form. I was playing with this design a little bit earlier, and the first thing I'm going to do is switch it to G-Sim. I think you did have a couple lenses along the way that you had designed in G-Sim, and for this particular cornea, I think that'll work just fine. When I left it in freeform and tried to make changes earlier, it was getting a little bit confusing, and there's a lot of fine-tuning, especially here at the reverse curve, that I had to do. So I'm just going to go to G-Sim. You're using a slightly smaller diameter than initial. I think that's okay. You're still getting pretty good centration. The initial 10.8 that was there before I think would also work really well. But I'm going to go to G-Sim because it does make the design of the lens much more easy. And looking at this cornea, it is pretty regular. I think the lens will fit just and center just fine in with a G-Sim design. So I'm going to shrink the optic zone right now. I think we're at a 6268. I'm going to go all the way down to a 5460. And then we have to adjust the power. We're going to be overcorrected now. It was around a 1.66, I believe, before. So I'm going to reduce the power until we're about there. And all this is in 100% mode. And we're there. Okay, so 1.63. And the next thing I'm going to do is go around to the individual meridians and make sure it's fairly symmetrical. So this one's off. I can probably get that one a little bit closer. Okay, so that looks pretty even all the way around. We're not getting any unusual kinks in the reverse curve here, and that's what I was getting with the freeform lens. So, and looks like we're getting pretty good bearing peripherally, a little bit of central clearance, which I do like to leave in there. And okay, so now we've got a smaller optic zone. I found that reducing the optic zone doesn't introduce too many halos. As long as the patient didn't really have any before, it might make a small difference, but not nearly as much as I thought it would when I first started doing this. So I'm not too concerned about introducing halos. What we're doing here is we are just reducing the amount of tissue we're having to mold in hopes that moving smaller amounts of tissue will be less likely to introduce irregularities like that we're seeing here. And then the other thing you're going to do is add in some asphericity. So before I do that, we'll want to make a note that our topo demand right now is about a 6.91, because that's going to change when we add in plus 0.2 seems to work pretty well for me. And so you'll see that centrally the lens is bearing down more. So we're getting more bearing centrally right at the center of the treatment zone, and the idea is if we can get more regularity here, for whatever reason the fluid dynamics are not acting uniformly across the central millimeter or two. And what we've done is we brought the lens down, and hopefully that'll smooth that out for both eyes. So you'll see that the topo demand went up to 7.88, and we want to drop that down to 6.91 where we were before. And I'll fudge on the higher side. Okay, so now you'll see how we have a lens. The power is completely different because it's aspheric, but you get a lot more central bearing. We're not molding quite as much tissue, and I may touch up that edge here a little bit too. I want to make sure this lens stays aligned on the cornea really well. Okay, so this lens looks like it's going to align pretty well. We've got more central bearing. I do find that I get a little bit of staining when I switch over patients to aspheric lenses, and they also get a little bit of discomfort sometimes with the lens. So as long as I don't see anything that worries me, I do have the patient just continue with the lens. I've even had patients alternate between the new lens and their most recent lens in case they're having trouble adjusting to how the lens feels. But I would try this. I'd recommend maybe trying it just with one eye first to see if it helps, because like I said earlier, I do have cases where no matter what, I haven't been able to get rid of that bow tie in the middle. The patient is getting acuity, pretty decent acuity, but the quality of the vision is not ideal. Hopefully this will help a little bit with that, and I wish you the best of luck with this patient. Thanks for watching.